other than our pneumonia patients, we have all these other respiratory inflammation types of conditions that result from an infection. Now, the only other one that is really big in terms of like a 911 emergency that we are really very, very highly aware and responsive to is our bacterial Epligititis patients. I'm going to put that down here. Epligititis. Pneumonia is the one that we're most concerned about in the hospital, but epiglottitis is that inflammation of the epiglottis. Now, the epiglottis is the little flap between our respiratory tract and our GI tract. So if we draw like a GI tract over here, I know this is not how it looks, but there we go. That'll be our esophagus and our trachea. You know when you swallow something and you say it went down the wrong tube? Well, your epiglottis here is like a little flap that closes your trachea, your windpipe, when you're swallowing something. So we don't swallow things directly into our respiratory tract. Kind of cool, huh? Well, when our epiglottis gets inflamed by a bacterial infection, usually what supersedes or precedes any type of epiglottitis usually is a viral infection. Basically, a viral infection will lead to a bacterial infection. Usually 9 times out of 10 in any one of these types of infections. So your epiglottis will be so inflamed that it's going to constrict our breathing. And it's a 911 emergency. That's why I circled that, put a little star next to it. Because if your patient comes into the hospital, or if your patient is already in the hospital, and we have basically drooling, hoarseness, difficulty breathing, any type of difficulty swallowing, and you'll actually see your patients drooling from the sides of their mouth, not being able to talk. They're having probably epiglottitis reaction, or if it's not an allergic reaction or something like that, it almost looks like allergic reaction, but that is an emergency. We need to intubate your patient immediately and give them an ET tube, which is just an endotracheal tube to help them breathe. But the biggest thing we can do for any one of our patients here is watch out for their ABCs, their airway, breathing, and circulation. So what are the nursing interventions other than giving your patients antibiotics, turning them, coughing them, deep breathing them, promoting anti-infective asepsis techniques? We're going to be doing chest x-rays, which is not really a nursing intervention, but we have to schedule that and collaborate that with our people outside, basically our radiology department. We have to gather sputum cultures, especially with your patients with pneumonia. A sputum culture we want to see is your patient getting better or worse. We're going to get that sputum culture, send it off to the lab, and if your patient has a decrease in infections, that's a good thing. If they have an increase in infection, it's a bad thing. We got to switch up our plan of care. So 2 contraindications with epiglottitis: do not give your patients any type of tongue blades inside their mouth, and do not try to get a swab in the back of the throat to get a culture. Those are 2 contraindications that's going to inflame the epiglottis even more. So just watch out for that with your patients with epiglottitis. Pulmonary function tests. Pulmonary function tests usually only done by your respiratory therapist. So your RTs will take your patient to the pulmonary function test area, and they'll do a pulmonary function test on your patient. pulmonary function tests, all they are is measuring the function of the pulmonary units. Right? Sounds good, huh? Okay, cool. So there's three major criteria for your pulmonary function tests here. Now, usually registered nurses are not the ones that are doing the tests themselves, but we have to read the results. So for your PVC, this stands for your volume of air exhaled from full inhalation to full exhalation. So they're gonna get your patient on a machine, hook them up. It looks almost like a telephone. This is a peak flow meter. We'll talk about that later. But it has like a little wire, and they'll hook them up and take a deep breath, and then so full inhalation, full exhalation. That's your PVC. So it stands for, again, your forced vital capacity. Full inhalation, full exhalation. Now for adults, they said it should be anywhere between 75% to 80% or higher, and that means that you're normal, okay? So 80% or higher means normal. For your FEV1, this means that you have a volume of air to be blown out as quickly as possible during the first second of your forceful exhalation after full inhalation. Sounds pretty confusing, right? So all we're just trying to say is, how fast can you push the air out as a forceful exhalation? Almost the same thing that we're doing when we send your patients home with one of these contraptions called the peak flow meter. Peak flow meter, I'm kind of jumping ahead, but I had to use a peak flow meter when I was a little kid because it shows, well, it doesn't show, it pretty much measures the amount of air that you can forcefully expel from your lungs. And we usually do this in the morning with your asthmatic patients. So we kind of just want to see how the day is going to go. Because if your patient wakes up and let's just say flows like a 200 on your peak flow meter, not going to be a good day. We usually want your patient up here, and I think when I was little, my goal was to get like a 600. But at the doctor's office, we're going to blow and see what your normal is. And then we put like a green marker. They have like these little like markers here. Well, not a marker, but they have like a little tab you can move up and down. And say, oh, cool, you know, like on Tuesday and Monday, I scored a, 450. And then after, let's say, after I went to hiking or had a very, very exhausting week, on Friday I did like a 200 in terms of your peak flow meter. So we're going to give your patient, that helps your patient to gauge, should I take my bronchodilator right now? Or basically, are my steroids being effective? Or maybe I've skipped my medications a little bit because I'm a kid, or my parents forgot to give it to me because I'm a pediatric, or let's just say I ran out, and my peak flow meter will be down here. So it just helps your patients to gauge for themselves. Every morning, I had to do it, read it into my peak flow meter for gauging itself. But that's for like home stuff, okay? For your pulmonary function test, I know I kind of like jump all over the place. For your pulmonary function test, at least, this is the hospital stuff, okay? So your hospital is recording these values on your patient's chart. So we went over the FVC, the FEV, and then your last one is your peak expectoratory flow rate, your PEFR. Now your PEFR is measured using a peak expectoratory flow meter, or peak flow meter. Yeah, cool, huh? And it's the maximum amount of air that can forcefully be expelled from your lungs, what's known as expectorated, in 1 second, okay? Blowing out. This is what we're going to be doing and sending your patient home with. And it kind of measures how well your patient is doing on that day-to-day basis, as we were saying. And the cool thing about this is that your patient comes in, let's say at 6 months, let's say 6 months ago, your patient comes in, newly diagnosed juvenile asthma or exercise-induced asthma, and they're having a really tough time breathing. And let's say that they're scoring like a 200 on their peak flow meter. And then after a few months of giving them bronchodilators before they work out, bringing out the, making your airways bigger, right, dilating the bronchos, giving the steroids, giving the anti-inflammatory agents to making those smooth muscles in the bronchi decrease, maybe even putting your patient on a, what's it called, anticholinergic agent, those ones that end in -ium. Maybe doing like a whole cocktail of stuff. Your patient comes back in, let's say, 2 months or 3 months or 6 months, I don't know, and now they're scoring like way up here, and let's say the 700. That's great. It's huge. Because honestly, if we didn't have a peak flow meter, if we didn't have any of that stuff, we wouldn't know if your patient's getting better or worse. I mean, obviously your patient's signs and symptoms, we would know that way, but quantitatively, in terms of numbers, we know specifically how much greater they have expanded their lungs, how much greater they are breathing in, and how well their lungs are doing in those pulmonary function tests. So it's very awesome that we have those kind of contraptions nowadays. And, medicine's exciting right now because there's so many new technologies happening. Like, we didn't even have EKGs until like the 1940s, which was pretty interesting to me because that earthquake paper has saved a lot of people's lives in the past years. We didn't even have EKGs in terms of your cardiac stuff. We didn't have those on ambulances in Orange County, where I work, in California, Southern California. We didn't have them on ambulances until like 2000. That's pretty bad. That's like horrible almost. I think it's horrible. Because an EKG, they want you guys to do an EKG for your cardiac patients, your myocardial infarction, your heart attack patients, within 5 minutes of onset of substernal pain. And if we don't even have them on an ambulance, ambulances are first responders, that's horrible. So I'm glad that, medicine is accelerating as fast as it is. But I'm done with my rant. Let's go on to collaborative care of asthmatic patients. Holy moly, this is a big one. Huge. This, we're going to be covering really the most common types of respiratory illnesses here. Now, I want you guys to think in your mind, COPD is a chronic obstructive pulmonary disorder. It's not necessarily an infection, even though infections could set in. For your bronchitis, that is inflammation of your bronchi, okay? The big bronchi of the respiratory tract. Now, bronchitis, means inflammation, and we're fitting them in right here. So any type of inflammation leading from an infection is what we're talking about here. So the biggest one here, if you guys can see that, let me see if I can move it closer here. Common type of respiratory illnesses. The biggest one that we stress in nursing school is our pneumonia patients. So we have all these other types of illnesses or infections, But the biggest one that we like to focus on is pneumonia. Really, if we break it down, there can be an infection at any portion of our respiratory apparatus. So for your nasopharyngeal cavity, basically your nose heading down into your airway passages, we have nasopharyngitis. For your pharyngeal cavity, you can have pharyngitis. For your tracheal cavity, your trachea, you can have tracheitis. For your bronchi, you can have bronchitis. For your bronchioles, you can have bronchiolitis. Right? Does that make sense? You have infections and inflammation happening at all portions of your respiratory tract. Now, for pneumonia, pneumonia is the extra large, biggest complication in terms of leading to death that our hospitals are seeing the most of today. A lot of people that have gone under anesthesia come out of anesthesia after a heart attack or after a big surgery, and if they're not using their incentive spirometer to reopen those alveolar sacs at the bottom of our respiratory tract, atelectasis sets in, secretions set in. So if those secretions are sitting around for too long, it's almost like a pool that has not been cleaned for a while, and bacteria sets in, and that's where we get an entire whitening out. When we see it on the chest x-ray, a whiteout we call it, basically pneumonia, all just infection and fluid in the lungs, and we can't exchange oxygen on our alveolar sacs. Basically, oxygen meaning the money of the body, we can't exchange it, so our patients, that is the quickest way that patients die in the hospital from those types of infections. So be careful with your patients, please. Make sure that we're turning, coughing, deep breathing. We're giving our antibiotics on a regular basis. We're listening to our patients, their lung sounds. Let me see here. I'm going to focus on a few here. So for our data, for any one of these, I want to focus really on pneumonia. That's the big one. For our data, our patients will present with a fever, obviously, because we have a big infection inside of the respiratory tract, as well as your patient is going to be having rhonchi in terms of listening to your patient's respiratory. So rhonchi, as well as crackles for your pneumonia patients. The biggest thing that we can do for our patients is turn them, cough them, deep breathe, turning, coughing, deep breathing, giving them antibiotics, listening to see if the rhonchi and the crackles, basically the fluids in the lower portions of our respiratory tracts, those alveolars, are getting better or getting worse. That's how we do our nursing process. We have our data, our action, turning, coughing, deep breathing, giving our antibiotics, are basically the results. Is the patient getting better? Is the patient getting worse? Let's assess them again. Assess. That's our biggest nursing interventions for your patients and really any type of diagnosis here. So let's talk about tonsillectomy as well as tonsillitis. Now, tonsillitis is an inflammation of your tonsils. Itis meaning inflammation, tonsils meaning your tonsils. If you guys have a tongue compressor at home, you can put the tongue compressor in your mouth, look yourself in the mirror, and go, ah, and see these two big red things in the back of your throat, and those are your tonsils. So all always, always, always start with the pathophysiology. So your tonsils are a part of your lymph type of lymphatic system. It's very vascular. Your tonsils help protect your body from any type of bacteria or any type of viral infections. They're located in your pharyngeal area, right at the back of your throat, and they help protect your respiratory and your GI tract from any type of bacteria or viral infections. Now, for your pediatric patients usually get tonsillitis a lot. Not so much with your adult populations. Usually your adolescents, even the teens, usually get this tonsillitis, mainly because of an immature immune system. So these tonsils, they swell up. Not that big, but you get the idea. It swells up in the back of your patient's throat, and your patient has either difficulty breathing, difficulty sleeping because they're snoring a lot, difficulty swallowing, the secretions in their mouth, as well as, what's the last thing on this? Difficulty hearing. Just because the tonsils, when they get inflamed so much, they block the eustachian tubes leading to the ears, and it can block some hearing as well. So if your patient comes into the hospital complaining of, let's see here, any type of swelling in the back of their throat, coughing up of any type of bright red-tinged sputum, your patient will get an oral examination, and we're going to look directly at the tonsils. So what we're going to basically be doing for your data here, your physical assessment, we're going to look at the back of the throat. And we're going to see an inflammation of the tonsils. If your patient, I'm sorry, I keep burping here. If your patient has a high fever, for your physical assessment findings, indications because we have an inflammation or an infection going on in the tonsils. Your patient's going to present with a fever because an infection is going on in the tonsils here. You're going to have an inflammation and reddening and even edema, swelling of the back of the throat. So we're going to do a swab to swab for any type of infection. Now the infections that we're looking for here are any type of strep infection. Almost like the ones that we do for strep throat. But it's called group A, B, hemolytic streptococci. And we're looking for any production of colonies as we swab. We actually take like a swab, looks like this long. You go in the back of the throat, we swab it, we pull it out, put it into a tube and send it to lab and see if we find anything. Now you're going to be asking your patient again, do you have any difficulty swallowing? Do you have difficulty hearing? Does your patient snore at night? Usually you'll ask your patient's parents because sometimes you don't know to snore. But this is going to be more with your pediatric patients. So the first thing you guys do, the first thing we do is we're going to educate our patients here. With patient education. You're going to talk to the parents about giving your patient rest, cool fluids, warm, salty gargles in the back of the throat so we can sterilize the field. If we have to do an ectomy or a tonsillectomy and take them out, we're going to go into that right now. But the first things first, we like to do the least invasive first in the medical field. We do not like to go in and cut our patients up for the first line maneuver here. But we're going to add some medications here. We're going to give antipyretics for the fever, basically meaning your Tylenol or your NSAIDs, your non-steroidal anti-inflammatory agents. And remember, Tylenol is not an NSAID. Tylenol, and NSAIDs being like Motrin, or NSAIDs, the generic would be ibuprofen. We're going to give antipyretics for the fever. We're going to give antibiotics like amoxicillin for the infection going on here. And we're also going to give analgesics, not opioid analgesics like Vicodin or morphine. We're going to give something like Tylenol 3, which is Tylenol or acetaminophen mixed with codeine. And this helps to relax your patient. We usually give T3, Tylenol and codeine together for pediatric patients a lot because it's a little bit, it's less, what am I saying? It's less, it's not as strong as with opioid types of drugs here. But if the results come back and if the doctor says we have to do a tonsillectomy and we have to go in and we have to take out these tonsils, which usually happens a lot with our pediatric patients, the main thing with post-operative care with your patients in tonsillectomies is bleeding and airway obstruction. Don't forget, guys, do not forget. ABCs is our number one, especially with any type of surgery having to do with anything going into our airways, okay? So your patient comes back from a tonsillectomy. We're going to position your patient to the side to promote drainage. They just cut open and took out the tonsils. So there's going to be probably some drainage going on. You want your patient to report any signs and symptoms of bleeding. That's your circulation, okay? Any signs and symptoms of excessive pink sputum, bright red sputum. Now, obviously, they're going to be coughing up and spitting out blood-tinged sputum because that's normal. We went in there, we did surgery. But anything in excess with your patients with bright red emesis, let's see here. You're going to have your patient on a clear liquid diet and very cold fluids. So like ice cream, cold water, like ice water, more of a, what's it called, like popsicles. I'm sorry, I said ice cream. But we're actually going to avoid any type of milk-based foods because milk-based foods causes an increase in mucus production. And the last thing we want here is increased mucus production in the airways, or basically the pharyngeal portion of our body here. So we're going to give cold liquids. We're going to stop or basically have your patient not take any red liquids because that's going to show in terms of we're not going to be able to distinguish our red tinged sputum versus the red popsicle if your patient's having red popsicle. Let's see here. For your instructions for your patients, here's a big one. For a post-opectomy, patient education. These are big here. So write these down. We have our no-nos here. Do not do. No coughing. No excessive coughing, okay? We don't want to bust a stitch inside of our patient's mouth here. No blowing the nose. Nose blowing. Let's see here. No sharp foods like nuts. No sharp foods. No like nuts or like hard crackers or hard chips because we have an open wound here that's closing with stitches. We don't want to bust or cause any evisceration of the stitches inside the patient's mouth, okay? Let's see. Some complications, I know I'm going quick because I got it, but some complications is we want to prevent any type of hemorrhaging going on in your patient's oral cavity. Obviously, again and again and again, we're trying to prevent anything that involves ABCs, an obstructed airway, obstructed breathing, or any type of circulation problems in terms of bleeding here. So we're going to directly observe the patient's throat. We're going to have your patient report any excess of bright red tinged blood, okay? Or any bright red tinged sputum. Report signs of bleeding, as well as watch out for the number 2 killer in the hospital. We have our ABCs, and the next thing is watching out for fevers, which could be indicative of your patient going septic, because we just have an open wound inside of the mouth here. We want to watch out for bleeding, airway obstruction, as well as any type of infections that might set in the oral cavity. Cool?